Hi, everyone. Welcome to this week's edition of It's Worth a Shot. Hope everyone is doing well. It's hard to believe we're more than halfway through May, and school will be out in just a few short weeks for a lot of folks. So crazy, crazy how time flies. Today is May 17th, 2023, and welcome to this week's edition of Mountain Pacific Quality Health. It's worth a shot. And today we have a guest speaker from Hawaii, and we'll be touching base on a few updates related to the end of the public health emergency. My name is Jessie Kinsey, and I'm account manager with Mountain Pacific Quality Health. Next slide, please. So a few updates and reminders for this week. We have updated a couple of resources and loaded them to our website as of today, and we'll drop those links in the chat box for you. One of those resources that has been updated and released is the National Healthcare Safety Network NHSN frequently asked questions tip sheet or guide. That is a multi-page document with some common questions and solutions about that NHSN data entry that I know a lot of us have been mulling through and trying to keep up to date with. So again, we'll drop that link into the chat, take a peek at it. It may help you with some problem solving. And then we also just uploaded to our website a really nice decision tree on COVID-19 vaccines and trying to determine up-to-date status. So hoping this will also help a lot of folks out. And we'll drop that link in the chat as well. Thanks, Miranda. Next slide, please. Few housekeeping items. As usual, feel free to add your webinar topics or clinician ideas into the chat box. And if you have a moment at the end of our presentation, we would love to hear from you if you wouldn't mind completing that post-presentation evaluation. There's an opportunity within that eval where you can also add input or webinar topic ideas. We will continue to meet every Wednesday. And we do have a polling question for today. Do you feel like you're offering your residents all the vaccines that they are eligible for on a routine basis? Just give you guys a few moments to respond. Looks like lots of yeses. That's excellent. And I agree, it's hard to keep up. All right, we'll go ahead and end that polling. Thank you guys as always for participating. It looks like most folks, yep, you're keeping up. Some it's harder than others, and it's definitely does get a little dicey trying to keep up. So I can appreciate that. Feel free to reach out to me if I can be of assistance and help align you with any resources. A lot of those mobile vaccine clinics are offering multiple vaccine offerings when they come to your facility, and they're really helping take that labor and burden off the staff. So if there's any way I can help you in your region, please don't hesitate to reach out, and Miranda will drop my email in the chat box too. So feel free to connect. Next slide, please. And as we take a look at that weekly COVID-19 snapshot, we do have a few updates. As of last week, the 11th, the COVID data tracker will just there's some changes as far as how it will be displaying that data and information, and it will no longer be reporting aggregate cases and deaths, community levels, transmission levels. Which I know many of us had anticipated this change as far as the platform kind of pivoting as to how we were going to look at some of this information. So as we reflected on the last posted data, we did see a nice decline in hospitalizations and deaths and an increase in vaccinations. So stay tuned as we continue to see what the final update will look like as far as aggregated case and death data. Next slide, please. did it freeze on me? We can advance to the next one. There we go. Thanks, Mary. And COVID-19 community transmission levels in a similar circumstance. As of last week, the 11th, those data levels will no longer be calculatable. So there'll be some different views in which to look at that information. And it looks like there will be a new page displaying updated vaccination information on June 15th. So we're about a month out to look at that. All right, next slide, please. So with that, I'd like to introduce our return guest speaker from the beautiful state of Hawaii, Kelly O'Leary. Kelly, thanks for joining us today.
Hey, thank you. And I'll be talking about the end of this public health emergency that we've all been living under for the last 3 years. I did give this talk to our Hawaii Long-Term Care Infection Prevention Network yesterday. I do see some of our attendees. I will have some additional information to share from yesterday, but it seems like most of the questions are around when do we take off our masks? The source control. Next slide. This is a little of how I feel. I don't know how you guys feel, but the picture on the left is the, oh my God, you know, we've been living under this COVID cloud. We've been running this marathon. So now it's over. And the picture on the right is more like excitement. Yay, it's over, but I know it has actually opened up a whole bunch of other questions. So this is a little of how I feel right now. Go ahead, next slide. The CMS updates to make mention of the QSO 2313. I have only highlighted some of those infection prevention bullets to pay attention to, but you certainly want to familiarize yourself with all of these waivers that they have essentially said no more. So the first one is the alcohol-based hand rub dispensers. And, you know, at the beginning of the pandemic, hand hygiene, we just wanted everybody to be washing their hands. So we put bottles and everywhere. We, you know, hung up more dispensers, and now what they're saying is you can't have alcohol-based hand sanitizer everywhere. So you really do need to work with your facilities department. There are a couple things to be aware of. You can only have so much alcohol in a smoke compartment. So you really need to work with your maintenance person to really understand that volume. And if you're exceeding it with the current hand hygiene based sanitizers you have, you know, down a wing, usually a wing is considered a smoke compartment. And really, you don't need to have them everywhere. I think depending on what your hand hygiene audits are telling you, you know, are people comfortable with where they're at? Certainly, this is something to be talking about with your staff, the locations. Some concerns are around residents and potential safety concerns, I think maybe from drinking the alcohol-based hand sanitizer. So that's certainly needing to be considered. A risk assessment would be encouraged for you to be completing if you need to give yourself further guidance around placements of alcohol-based hand sanitizers. The reporting requirements, so this is through NHSN, is continuing. The cases, so antigen and or PCR positive tests will continue through December of 2024, except for the reporting of vaccination status for residents and staff. That will continue indefinitely unless there's some change. The educating and offering residents and staff COVID vaccines, that's going to remain. You have a date there, May 2024. And then COVID-19 testing, they're referring to the CDC recommendations. And then the focused infection control surveys, there's the 20% rule, and that will continue through 2023. I heard October 2023. So that will also be going away unless at the CMS discretion they want to continue or do a potential a focused infection control survey. The other one is the QSO 20-39, the visitation guidance. The only thing that I saw that was different was you need to post a visual alert regarding the status and what the source control recommendations are, what the visitor needs to be doing while they're in your facility. Next slide. Okay, here we go, CDC. So the universal source control was updated, the admission testing was updated, and then the appendix is where you would look for the metrics and what is recommended when you're thinking about broader use of source control. And always the reminder of following standard and transmission-based precautions. Some have asked where to find the precaution type for SARS. It is located in the CDC isolation guidelines. It's not going to be, well, it lists, you know, the type of PPE you need, but when you're looking for the type of precautions, you want to pull up that CDC isolation guideline, Appendix A. And just to make mention, I heard also that the HICPAC group is meeting to review this guideline, which hasn't been updated since 2007. And so we should be expecting an update in the fourth quarter of this year on the isolation guidelines. I'm expecting enhanced barrier precautions to be added, and who knows, there might be a new precaution type also added. All right, next slide. Let's talk about source control. So this is what it's recommended. If you suspect or confirmed anyone with SARS or other respiratory infection, so you can see they're clumping SARS infection or other respiratory infection. So we need everybody to be thinking, you know, SARS is just another respiratory infection. Source control is recommended if you've had close contact or you're a higher risk exposure with someone that's been that has had SARS. So I think we're all good with that one. That's you know, what we currently are using source control for as well. Go ahead, next slide. The broader use of source control. So want to make sure you guys are real familiar with that CDC core infection prevention practices. There are 8 of them listed, and it starts from leadership. So need to make sure you got that printed out. It's not a whole lot of pages, but that's for everything. We just want you to be thinking, you know, how SARS kind of rolls up into just your general infection prevention practices that you guys do every day. So the broader use of source control, if you have an outbreak of SARS or other respiratory infection. So try not to focus too much on SARS. You know, if you were to have a flu outbreak, you would be wearing source control. I think the harder part is this risk assessment. So maybe a memory care, you know, is higher risk because they're a little bit more challenging to, you know, isolate or follow transmission-based precautions. So maybe you're going to consider broader use of source control for that particular unit. Certainly it makes sense, you know, an emergency department or hospital type setting, you know, ICU, ED, that makes sense for broader use of source control. They refer to the appendix of the CDC document, which lists the different types of metrics that you can pay attention to. So just to be thinking about your facility and the higher risk areas, and if you would consider broader use of source control all the time, or just when certain metrics are met. So it's going to be trying to figure out when you're going to pull that trigger for this broader use of source control. The other one is if public health has recommended a broader use of source control, then that would be another example. And the one here is if the hospital admission levels are high. Next slide. This is the appendix that I was referring to. And as Jesse mentioned, those community levels and community transmission levels are no more. And so the SARS specific data is still going to be on COVID tracker, but it's going to be hospital admission data. So, you know, I'm putting myself in that infection prevention role in a facility, and it's just, it feels easy enough to just, I'm now looking at hospital admission data versus community transmission level. The COVID net surveillance includes 13 states, and they're going to continue to report COVID data, which will also give a little bit of a marker for what COVID is doing. And none of the Mountain Pacific states are included. And that is covering 10% of the US population. Next slide. I'm including a couple MMWRs, and it's really around why they chose hospital admission rates for us to follow. And the first sentence here in this, and this is the summary from this particular MMWR, that COVID-19 hospital admission rates from NHSN are a timely and suitable primary indicator for monitoring trends in COVID-19 activity. So I feel pretty good with just adopting that as now that's my community marker. Next slide. This is the other MMWR. I really liked this, this diagram just as a way for me to understand, oh, okay, so hospital admissions, that's going to help me understand what's going on in the community and the severity of illness, death certificates, so some of these are what public health is going to continue to monitor. But I think if, a long-term care is communicating with the hospital, or if you're in a hospital setting, you can monitor emergency department visits. You're already looking at the influenza, like the ILIs. So that's going to also, maybe that's your marker of emergency departments, ILI. It's just, you want to be able to pick something that kind of gives you a sense of what's happening. Next slide. The non-COVID markers or metrics are this respiratory net, although it is monitoring for COVID. You can see it's COVID, flu, and RSV. So here's that, SARS and other respiratory infections. So SARS and COVID-19 is just like, we just added another respiratory infection for us to follow. So you guys are already following these anyway. So this could be something else that you're paying attention to. Go ahead, next slide. And the ILI, certain you guys are already looking at this, and you can see how it's green, and our flu-like illness is down right now. So COVID's down, flu's down. Right now would be probably a good time to try to be looking at what your policies around respiratory illness season is going to look like. Next slide. Not sure if folks got to attend this town hall. It was on Tuesday, and I'm just adding a couple thoughts that wanted to pass along, some good reminders. I know you guys are updating your policies. So I think the particular reminder might be, if you have a separate testing policy, or if you have a separate COVID policy, you just probably want to combine them all into maybe a transmission based, or maybe you have a respiratory virus policy, but just making sure you don't have separate ones for COVID, and just to combine standard precautions. I really kind of like this. It requires critical thinking. And then the point about training methods, that using scenarios to help with muscle memory, that kind of goes back to the critical thinking. So I know a lot of folks have moved to the computer-based training model. Some also have skills labs. I would really encourage you to find some sort of infection prevention skill, and kind of mix it up every year. Don't just use the same thing. Maybe this time it's going to be cleaning and disinfecting, and putting scenarios together. So staff are really needing to think critically about what product you would use, what's the contact time, and you're observing them use that elbow grease to clean that particular piece of equipment. And then also, who's responsible for cleaning? That's really important. And would they refer to your policy? Other metrics to consider. So again, I'm putting myself with my infection prevention hat on, and what would be the easiest. But of course, you have to take this back to your facilities. I like the idea of the hospital admission level. Here's the example, maybe that trigger for broader source control is going to be greater than 20 new hospital admissions per 100,000. The other couple I liked were HAI data. Maybe it's that you're noticing you're having transmission issues. So putting on source control, which is kind of what you guys are doing anyway. When you have a lot of cases, you're adding that N95. Staff absenteeism, thought that was a good marker. I think that that's something to be keeping an eye on anyway, along with the influenza-like surveillance that you're probably doing. Next slide. So here's the hospital admission data, and I put the 4 states that Mountain Pacific covers. So if you're considering source control, maybe it's 15 new hospital admissions per 100,000. So when you're gonna, you're needing to keep an eye on it when it starts creeping up. Now you're gonna be talking to your staff about ahead of time what the plan is and what that trigger is for this broader use of source control. And maybe it's in only one particular area based on your risk assessment, but you can see Alaska is about maybe 4. Montana looks like they're about 3 new hospital admissions for COVID per 100,000. Next slide. And then you have Hawaii and Wyoming. Looks like Hawaii is like the highest at about 7 new hospital admissions per 100,000. And then Wyoming looks to be the lowest maybe in the group. Next slide. So that was on source control. Here's admission testing at the discretion of the facility. Few points, and I've just copied and pasted directly from the CDC guidance, but a few points, obviously when it's lower community levels or lower new admissions, new hospital admissions, lower level of community transmission. So maybe you wouldn't do admission testing when it's low. Oh, I meant to say, when there is a marker, and I did find that so if you remember your state and that everybody was below 10, but green, there's green, yellow, orange. If you can maybe go back one. Thank you. The green is less than 10. Yellow is 10 to 19.9. And orange level is greater than 20. So maybe you're looking at that green, yellow, orange as your marker to source control. Okay, next slide, thank you. And admission testing. So looking at that new hospital admission level. If it's worked for you too, and you've picked up on a lot of cases and you've been able to put folks in isolation and prevent spread that way, then, certainly that's a strategy that you want to keep. Of course, expense and isolation and all that need to be considered, but if it's worked for you, certainly keep it, but these are just some considerations. And then if you're doing admission testing, it should not be based around the vaccination status of the resident or patient. Next slide. Just to make sure that you're looking at your state-specific updates, and reportable diseases are all being reviewed right now, and each state is doing it a little differently. So making sure that you are understanding what your state is requiring from you. Everybody's updating their websites to reflect that. There could be state-specific guidance, so make sure you know if there is a state-specific guidance. Maybe there is something that's going to say when to put on broader use of source control. There will continue to be outbreak reporting, so when is that trigger for you to continue letting the Department of Health know? And this is just an example of the Hawaii advisory. So go and find out what your Department of Health is changing and requesting for you to do now. Next slide. And just my last 2 pictures are just, we made it, we crossed the finish line. Many thanks to you and your team. Great partnerships all around, and, high fives. And the work, continues just because we're moving into a different phase. But I think that your Department of Health and Mountain Pacific, we're here to help. Thank you. That was all. questions?
Thanks, Kelly. I'm just flipping through chat right now to see if we have any questions. I don't see any. I know Miranda did drop the links to several resources that were mentioned to be updated on our website, so feel free to snag those. And then, oh, there is a question in chat there. Deb says, I'm having a hard time locating core IPC on cdc.gov. Deb, feel free to come off mute too if you'd like.
So yeah, according to their new guidelines, they want us to post visuals in the entranceways, you know, if a visitor has COVID or the signs or symptoms, to defer the visit. They want us to post, you know, hand hygiene stuff. And then they also said something about posting the core infection prevention practices, the 8 of those. And I couldn't really find anything in detail, you know, as far as something that I can post as far as like a poster or a flyer or something. Is anybody else doing anything?
It looks like Erica Baldry popped the link to the CDC core infection practices. So we can follow that.
Oh, maybe that could be interpreted as that you want to inform your visitors or, you know, whoever to, you know, what you're doing around staff test, staff education and training. That's number 2. Patient, family, and caregiver education. What are you doing around that? That you're following standard precautions, and I'm not quite sure how much detail they want.
Yeah, I mean, I wasn't sure how deep we could go in, or, you know, how, like, what detail they wanted, but that might help, Erica. I think I was there on this page today, but I'll do some more digging. I guess maybe on our Friday call, we can clarify for sure exactly what they want us to do.
Thanks for the question, Deb. Good question. And we'll look around too between all of us and see if we can find updated links to signage. I'm just looking at this link that Erica sent, and there's tons of good info in there. So,
hi, this is Maria. Yeah, we just created our own signage to put at all the entrances and nurses stations and around the visitation areas. And I think we have like 6 different signs. And one of them is, you know, the symptoms of COVID. And if you have any of these, please don't come in. Another one is, you know, if you've tested positive for COVID or been around somebody who's been positive for COVID in the last 10 days, please, you know, delay your visit. And then we have a couple for hand hygiene with alcohol-based hand rub or soap and water. We are still requiring visitors to mask. So we have a sign about masking to be in the facility. And then there's one that's just got kind of all of the strategies in little pictorials, like an infographic all together, you know, masking, hand hygiene, distancing. Yeah, they're just little cute flyers that are just posted everywhere.
Well, thank you for sharing that. I have everything that you listed, but the one that you said is just kind of about the masking, the distancing, the kind of that particular one. Would you be able to forward that to my email or share that? Everything else I think I have covered that you had mentioned. I'm just having a hard time with the, you know, in detail, the masking. And I guess we could make one too also, but if you have that handy to share, that'd be awesome.
Deb,
Yeah,
will you pop your email in the chat box too?
You bet. Thank you.
Okay, thanks.
Jesse, it looks like somebody else asked for it as well. So if you want to send that to one of us here at Mountain Pacific, we'll make sure that all the attendees get that email.
Perfect. Love it.
Thank you very much.
Yeah, thank you guys. Thanks, Deb. Thanks, Maria.
Yep.
And there's a couple more questions. I see we're right on the hour, but we'll see if we can sneak these few questions in here. quick question. Has anyone stopped masking and went through a state survey without citing?
We did here in Newcastle, because we were masking according to the community transmission level. And at that time, we were low. So we were not masking when state was here. And this was just maybe a month, maybe a little more ago.
Okay, that's good news. Good news to share for sure. And then a next question, if you've never had a COVID vaccination and then get a bivalent, are you considered up to date? Yes, you are. Yes, you are. As of that 19th guidance from last month, April 19th, with that bivalent guidance change, if you get the bivalent vaccine, for the most part, you would be considered up to date. And you can call it good. So good question.
Do you see that question real quick about from Dana? Should employees still mask at hospitals if they are unvaccinated for COVID? I just wanted to say or put back to you, what do you do for flu? What do you do if your employees are unvaccinated for flu? So just trying to have you think about, you know, COVID as a respiratory illness.
Thanks, Kelly. So it looks like this is just the time to reevaluate our policies to whatever we're choosing to do. It matches our policy. Is that what I'm understanding, Kelly?
Yeah, to kind of clump in COVID with your other respiratory. I see, let's see. Oh yeah, Deborah, our unvaccinated staff tests weekly. So that, if you do something for flu to, consider that for COVID, or, what's different with COVID or flu, probably testing is going to be a little different for exposure, but yeah, to kind of look at having it like a respiratory virus policy and how it's different between the RSV, COVID, flu.
I have a couple of comments, questions. So I think the challenge with that is that I don't know that we've yet determined that COVID is truly seasonal, like the flu sort of is. And even in Hawaii, the flu's seasonality is kind of a messy prospect. But, when CMS is doing away with the vaccine mandate, but I haven't seen them publish anything about, there was a requirement that what are we doing to keep our unvaccinated or keep our residents safe from the unvaccinated, right? Like what measures have we put into place to mitigate the fact that they're not vaccinated? Is that going away too, or are we still going to have to do something different or show some higher level or added precautions based on vaccine status? Does anybody know?
I'm thinking that memo is still current. Mountain Pacific folks. Good question. We can follow up.
Yeah, good question, Maria. I'll have to look because I'm thinking those additional precautions. I'm running through my brain and I don't know if I've seen an amendment or update to that, but we'll definitely find out.
No, we're out of time. Can I just add real quick? So we did just have state here and I did get dinged because we were not doing anything above and beyond what everybody else is doing for our unvaccinated. So for example, prior to them coming in, everybody was just checking their temperature and then they would report to me if they had symptoms. So every single employee in the whole facility was checking their temperatures. Well, they didn't like that. They said that our unvaccinated staff had to do something above and beyond what everybody else is doing. So last week we started testing them weekly again.
Okay.
They can't do what everybody else is doing. It has to be more.
Has to be an additional precaution still. Okay.
And I guess that's what's really frustrating, right? Is why are you doing away with the mandate if we still have to treat them differently?
Right.
If the vaccine's important, that we have to have these two different standards for vaccine status, then that's, I guess that just adds to the burden for us, right? Like we're not going to mandate it, so you don't have to, but we're going to have to do these extra steps if you opt not to get vaccinated.
So here's an example of maybe, you know, I know some folks have, if you're not vaccinated during the flu season, you have to wear a mask. So this could go back to Dana's question about what do you do, or, you know, this discussion about what do you do for the unvaccinated. Testing weekly, that's a lot of time and money to do that. So maybe to go above and beyond, maybe you would have your unvaccinated wear source control. And whether or not that's during flu season or all year, because you're right, Maria, we haven't really established, but maybe it goes back to that metric that you're going to monitor. That the unvaccinated wears masks.
I just want to jump in really quick, sorry, and clarify something. The mandate hasn't changed yet, right? For staff vaccination?
That's correct. This is Jill with Mountain Pacific, and I think the conversation, I think you're onto something, because right now the CMS has not yet updated that mandate. Right now it is still in effect, and so I think a lot of this might be clarified once CMS does release their updated guidance regarding staff vaccination.
And also in the past, even before COVID, there was, I mean, I don't know if it was a CMS mandate, but there was always extra precautions that staff members had to take who weren't vaccinated for influenza.
Right.
So
Thanks.
I don't know. Yeah.
Is this Lucy?
Yeah, I just want to
Thanks,
make sure.
Lucy. Yeah, I think we'll definitely keep our finger on the pulse of any updated communication that's released, because that is, I think, as Jill said, you're definitely onto something. So, well, thank you.
Thank you.
Well, if anyone has any questions, feel free to shoot us an email. Great conversation. I think we're all on the same page, and a lot of us have many of the same questions. So we'll continue to work together to help support those needs and answer questions, and great discussion today. So thank you all for participating and leaning into the conversation. So thank you, Kelly, for being our guest speaker today. We sure appreciate it. And same time, same place next week, and I hope everyone has a wonderful rest of their day. Thank you. Take care.